welcome to this very special WHA side event themed What Next for Surgery and Anesthesia, Civil Society and Global Solutions. It's a pleasure to see how many of you joined us here today, and it just goes to show once again just how strong the global surgery community is and how rapidly growing it is. My name is Dominique Vervoort, and I'm a fifth-year medical student of Belgium and co-chair of InciSioN, the International Student Surgical Network. Until a few years ago, global surgery was an isolated component of healthcare. 5 billion people remain without access to safe and affordable surgery and anesthesia in the world, and as a result, about 30% of the global burden of disease is attributable to surgically treatable conditions. As a result, about 17 to 18 million people die every year due to conditions that could be treated with access to surgery. To overcome all of this, by 2030, about 2.28 million additional surgeons, anesthesists, and obstetricians are needed to provide the additional 143 million surgical procedures every year. However, in the past few years, more and more attention has been given to global surgery and to anesthesia. And the peak of that has been on May 22nd in 2015, when the WHO adopted their resolution on strengthening emergency and essential surgical and anesthesia care as a component of universal health coverage. After this, more and more interest had been given to global surgery and anesthesia, and as far as I know, this year is the first edition where it was even almost a global surgery date clash. As part of InciSioN, it's a very exciting time to be a medical student, and it's exciting to see what an impact medical students can have, both for themselves and both for the field they are currently working in. To showcase this, I would like to draw your attention to the screen to show our most recent project in collaboration with Lifebox, with an excerpt of the checklist effect.
When the power is off, or when you get that power cut, it is disturbing.
And it's led us to judge that we need to go back to basics.
In Haiti, to lose a breadwinner is a huge burden on the family.
We've got to the point where surgery is now, within the wider hospital system, a much more complex and potentially dangerous environment to be working in.
I don't mean to transform this in a tragedy, but you cannot imagine when you have a problem that can be clearly be prevented.
Actually, we need to teach how to fish, but we are going to go to rural area to the surgeons, and not only to teach them how to fish, but we do the fishing together.
Thank you. We at InciSioN, we are the medics of the resolution. We begin our professional lives knowing that surgery and anesthesia are growing priorities of healthcare. However, still is much to be done and still is much to change. And looking around at the room today and to my fellow panelists today, I'm happy to see how much is already going underway. For now, I would like to give you the word to Ms. Chris Torgeson, CEO of Lifebox.
Hi, everybody. So I'm Chris Torgeson. I'm the new CEO of Lifebox, working on safe surgery and anesthesia around the world. And I'm so pleased to be here and to welcome all of you. And I'm also really pleased to be joining what I really see as a growing movement to bring safe surgery and anesthesia to the billions of people around the world who do not have access to it, as Dominique so rightly said. And I think the student groups, like InciSioN, are such an important part of this movement, not only because they are the future, as everyone always says, but also they have the incredible energy and drive to help really bring this movement along. And of course, they're also really good with social media and have done an incredible job. What Dominique is very humble in saying is that they actually mobilize students from around the world to translate this film and put the subtitles on in all these languages so that we could have it available. And I think that's just so remarkable. And we really see them as a core component of this movement. And I also have been very excited as I have just been joined this movement to have had the honor to visit Zambia recently and to see the incredible strides that they are making, the incredible challenges, but also the incredible strides they are making in improving the conditions for safe surgery and anesthesia in their country. And we are very honored today to have with us not just one, but two members of the delegation of the Ministry of Health of Zambia. And I see many friends and partners here that are part of this movement. And as many of you know, that Zambia has been one of the first countries to develop a national surgical and anesthesia plan. And so we are honored to welcome today both Dr. Javon Miranda, who's the permanent secretary of the Zambian Ministry of Health. He's an accomplished general surgeon. I'm also told he's a great teacher. He worked for many years at the biggest teaching hospital in Zambia that I know many of you here have worked in or had the privilege of visiting before moving to his current appointment as minister in the Ministry of Health. We're also joined by Dr. Mzaza, who we met at the event recently at the G4 Alliance, and we're both going to have them talk a little bit about the challenges of putting together the National Surgical and Anesthesia Plan and what civil society can do to help support implementation of that. And then they will hopefully also join the panel if time allows. Dr. Zaza, I think, would you please like to come up to say a few words about the? Thank you. About the plan, yes. Thank you so much.
Good evening, and it's indeed an honor to be invited to talk about the NISOAP, that's the National Surgical Obstetrics and Anesthesia Plan. I know, being pioneers, we tend to expose ourselves since we are actually the first, and the others will be following, or at least have some direction. But I should mention to say what made it easy was actually the support we got from various organizations. Last time I was at a function, there was Dr. John Mira from Harvard University. His team did quite a great job. And they were with us from the beginning up to the time that we had a document. And I was told SWAG would be here, one of the research fellows. They were quite a great team, but we had other universities and indeed other organizations. Among the major challenges were that surgery has been run by the Ministry of Health in its hospitals, mostly in the bigger hospitals. And these bigger hospitals are quite few, about 40. They were the ones which were offering formal surgery. But Zambia is a big country with about 105 districts. And if you distributed these 40 hospitals, they would definitely not cover all these hospitals. we have first level hospitals where very minimal surgery was being done. And all these smaller hospitals were referring to these 40. And even in these 40, the people who are providing surgery are not surgeons per se. They are physicians who have been oriented in surgery. Now, for surgeons, you know what that means. You are not assured of the quality of surgery. You are not assured of the information. And time and again, when you are just doing something for the first time, you make so much effort to do the best, and that leads you to make mistakes. Whereas if you are used to doing that, it becomes part of your routine, which is why we try to encourage specialization. So for us to get the baseline information or to do the proper situation analysis, it was a bit difficult. More so when we look at the surgical audits, because all the others who were offering surgery were not having a surgical audit. So if you look at our plan, it is blank when we look at perioperative morbidity and mortality. We could only establish from the 15 tertiary hospitals. We couldn't get any information from the other 25, and indeed the other smaller hospitals. And I think for the others who will be making this plan, that's something that they need to prepare for, and they will have to start from the time that they start implementing that each and everyone has to do some bit of audit. But nonetheless, that's history now. We have the plan. We know where we want to go. If you allow me, I could highlight a few things on the plan that I thought we should share. Our plan has the 6 World Health Organization pillars. We have service delivery, the human resource for health, infrastructure and equipment, information management. I think I highlighted that it was literally lacking in most of the facilities. And there was no evidence, so there was no research. Financing, leadership, and governance. The question is, where would the civil society come in? I know most of the non-governmental organizations have their own backgrounds. They have their own interests. For example, we have Lifebox. They are particularly interested in anesthesia. So we would not say we would have one thing that would fit all. These 6 pillars will be the guiding lines. In service delivery, if we are going towards universal health care, it means we want to have surgery at the lowest of the facilities. Last time at the last event, I mentioned to say that the Ministry of Health in Zambia has been undergoing restructuring, where we have changed the entry point of a client or patient from a health facility to the household. And we, within a few kilometers, would want them to be able to access a facility. I mentioned to say, we don't want people to get sick. We want them to remain healthy. So we have a directorate that deals with health promotions, environment, and social determinants. And most of its personnel have been posted to the community. But we still have a gap there. Most of our community health workers are volunteers. That is a little bit difficult to sustain. They can only volunteer for so long. However, the Ministry of Health has decided that they should start training community health assistants for 1 year. They are not yet deployed, and that's because of limitation in resources. But these are supposed to be right in the community. Our smaller facilities, or the first level facilities, were designed to offer certain type of treatment with quite little on surgery. So if we are going to implement this plan, there should be some modifications to these facilities and change in staffing. Our approach is primary health care approach. We want it right at the lowest facility. We are doing a little bit of surgery for minor injuries and so on, but we want the district hospital to be able to save that dying mother. I mentioned, say, we failed to reduce the maternal mortality according to the MDGs. And it's because we never took surgery down there. And if you look at the magnitude of the problem, almost all those things that cause mother's death, eclampsia, bleeding due to delivery, obstructed labor, malpresentation, fetal distress, all those can be sorted out by surgery. But women had to travel about 200 to 300 kilometers in very bad roads to access this surgery. And most of them ended in mortality. We know that a healthy nation or a healthy people are the ones who would contribute to the economic development. We have so many accidents, both road traffic, falls from heights, and the human-animal conflict that we usually have, which lead to disabilities. And if surgery is not there, they will be disabled. Not only will they fail to contribute, but they will take away man-hours of the able-bodied to take care of them. That requires surgery. Congenital disabilities. We do not have the personnel to do the screening. And that's why we are thinking of that community health assistant to be right in the community, do the screening, and quickly refer appropriately. There are indeed many acute surgical conditions. I won't go into the details. So the issues are only human resource, where the civil society can come in, infrastructure and equipment, where we need to modify these facilities, sustainable financing, leadership and governance. So as civil societies, you could pick which area you would readily fit in. I will share the list with the emails so that immediately the plan is launched on Friday, all those that have attended will have an electronic copy of the plan. Thank you.
So I think we really want to congratulate Zambia on putting together this plan, and Dr. Mzaza has so well outlined both the challenges and priorities of that plan. We're now very honored to have Dr. Javon Miranda speak for a few minutes because, as you can guess, their time is very limited here. And he told me yesterday when I had the honor to meet him that he had to be here, that this was a passionate issue for him. So we would very much like to have a few words.
Right. Thank you. Thanks very much. This is indeed a very important meeting for me. I feel so passionate about it, and I'll try and explain why I think so. First of all, it's nice to meet those of you that are associated with the anesthesia world, because many years ago, one of the former presidents of the Anesthesia Societies Federation was actually teaching me how to intubate somewhere in the late 80s. So I feel close to all of you here. But perhaps let me talk about what made me become a surgeon. Apart from that, I used to see a big light through the window when I walked past the hospital, and I wondered what was going on. You see a big light hanging. And I thought maybe I needed to work in there for me to know what goes on. And I started thinking about it that early. But actually, what gave me the push was a story about a gentleman who was 2 years my senior in med school. He was deployed to a rural hospital. And for the very first time in this rural hospital, they had a doctor. And the community were extremely excited, very excited. But here was the problem. In the rural parts of Zambia, if a woman is brought to you with difficult labor, you know that she's been laboring for several days. And so every time they took a woman to this doctor, look, we have a problem here. And he told the community, can we find some money, put together, buy fuel so we can drive this woman to the next hospital? And you know what the outcomes will be like. So it went on for some time, but the community realized this is not the kind of doctor they were looking for. And they used a local term, which means, how can you be called a doctor if you don't know, now literally translated, if you don't know how to open the abdomen? You cannot be a doctor. So the community actually rose up and demanded that he leaves the hospital. And that's how my friend left the hospital. At that time, I thought, until and unless I can do surgery, I'm not going to rest. So I became a surgeon. During my surgical practice, I saw a number of not so good things happen. Let me step back a little bit and tell you that my best, I have two operations that I really like. The first one is doing a C-section under regional anesthesia, spinal or epidural, whatever. Because I talk to the woman, deliver the baby, and if you have a, if everything goes right, it's beautiful. The other operation I like is the cataract extraction, because once the time you remove the iPad, I mean, it's like, well, it's a whole new life. So I find those two operations really interesting to do. I'm not an obstetrician, but I find the C-section better, very, very enjoyable, if it is done under regional anesthesia. But sometimes, and this happens, can you imagine you're operating on a woman and you're talking to her? Along the way, she quietens, and not too long after that, she's not with you. And that's because of a problem with the way patients sometimes are monitored. And so when I heard about pulse oximeters going all over the place, I was really excited because this can save many lives. So this is a very important group of people trying to do great work. And how do I see the role of civil society in this whole thing? Now, as Zambia, we have a plan. The reason why our public health colleagues think that, or our physician colleagues think that they are the doctors, and the reason we think public health is infectious diseases and not surgery, is because they probably got there first, not because surgery is not public health. Surgery is public health, like anything else. We have a plan, but the plan has got to be implemented. So this is where I see the role of civil society. We need to change the way we think, the way we regard surgery. We need to see surgery as essential. And this will require some advocacy to change the way decision makers think, particularly those that allocate resources. We know surgery requires a lot of things, a lot of inputs. Infrastructure, Dr. Ntele has gone through that. And that's important, but people have to change the way they see surgery if they are going to allocate resources. So part of your role is advocacy. Advocacy with the people that make the decisions, with the organizations that are able to provide what it requires to provide safe surgery. I also see the role of civil society in actually implementing and providing surgical services where possible. I also see the role of civil society in training particularly, because human resource is key to whatever we do. Unless we have people that can do it, it's difficult to implement the plan. So I was really excited to come to this meeting. I'm afraid I didn't have a prepared presentation to speak to you about, but I felt very strongly that I needed to be among yourselves. And thank you very much for allowing me to be here.
And we're very honored to have you and to hear your experience. And also, I think you gave us a good list of what our marching orders will have to be to help support you in implementation. I wanted to just point out that I did visit Zambia, and I was able to drop in at a couple of the district hospitals. And actually, this is a local nurse anesthetist, and I'm not the best photographer, who was using the pulse oximeter in Kafue. In a district hospital, and it was really great to see and hear her, and not only how she put the pulse oximeter into practice to better serve her patients, but how she had actually enabled teamwork in the entire OR to implement the surgical safety checklist as well. So very inspiring. So you already have some fantastic people on the ground that you have. So next we wanted to have an example. As Dr. Mwanda had said, human resources are so key to implementation of the national plans. We wanted to have an example of how civil society has worked to develop some thinking around that. And I'd like to introduce my new colleague and friend, Julian Gore-Booth, who is the CEO of the World Federation of the Societies of Anesthesiologists, the WFSA, which is much easier to say. Julian has over 20 years of experience in international development. Most recently, he was the interim director of international at Leonard Cheshire Disability, and he has held regional and country director posts for the International Red Cross. So he's going to present some of the work that the WFSA has been doing. And then we're going to have a brief panel of some other civil society actors, and we would be very honored if our distinguished guests from Zambia would be willing to stay for that. So we understand how busy you are, but we would love you to stay. So Julian.
Good afternoon, everybody, and thank you for coming. I've taken off my jacket. Please forgive me. It's hot in here. It's also a hot issue. When I look at so I looked at this and I thought about it, and I think about it all the time. What next for surgery and anesthesia? What are we doing about surgical, obstetric, trauma, and anesthesia care? And when I think about what next, one thing I know for sure is that we're only going to have impact if we work on this together. So this will be about a collaboration between civil society and governments and industry, because if we don't do this together, we will not have the impact that we seek. And we've been set this enormous challenge. One of the things I keep being reminded is that we now talk a lot about the 5 billion people who do not have access to safe, affordable surgery and anaesthesia care when they need it. And I keep being reminded to say that's out of 7 billion. That's 5 out of 7 billion. It's an extraordinary number of people who do not have what most of us should consider to be a basic human right. 4 times as many people die each year from neglected surgical conditions than die from HIV, tuberculosis, and malaria combined. Now there's a challenge for us. We're not going to meet those maternal mortality targets unless we include surgical and anaesthesia care in the solution. In 9 out of 10 anaesthesia departments in parts of sub-Saharan Africa, they do not have the equipment to give a safe anaesthesia to a child. And yet if you're in a country where 40 to 50% of your population is under 15, that's a pretty rate limiting factor. The key rate limiting factor is workforce. And to introduce some of the work that we've been doing on workforce, I would like to introduce my friend and colleague, Dr. Wayne Morris. He's an anaesthesiologist working in Christchurch, New Zealand. He has huge experience in Asia and the Pacific and other parts of the world. He was formerly chair of our education committee. He's now our director of programs. And he's going to give you an introduction to some of the work that we've been doing on the rate limiting factor, which we believe is workforce.
Thank you very much, Julian, for those very kind words. And it's great to see everybody here. I'd like to just pick up on some words that Dr. Mwanda spoke before, that we need to help people to understand the importance of surgery and anaesthesia. That's a very important role of NGOs like the WFSA and the G4 Alliance, civil society, industry. So Paul Farmer said that surgery is the neglected stepchild of global health. We heard 2 days ago from John Mera that there are currently 70 people employed by WHO to look at polio eradication. The WHO employs 1 person to improve access to surgery and anaesthesia. Now, I'm not saying that we should forget about polio eradication, but we do have a big job in trying to improve the understanding of the importance of surgery and anaesthesia. If surgery is the neglected stepchild of global health, then anaesthesia is his invisible friend. So anaesthesia does not have a high profile. And we have also heard several times this week that anaesthesia, or the lack of an anaesthetic workforce, is often the rate limiting step in the provision of surgical services. Many of you will be familiar with the findings of the Lancet Commission, which were released 2 years ago. The Commission concentrated on workforce for both anaesthesia and surgery, and they defined surgical, anaesthetic and obstetric providers. These were or are specialist physicians, surgeons, anaesthesiologists and obstetricians. They recommended the collection of core indicators, including SAO numbers. And they also recommended an increase in the SAO workforce to 20 per 100,000 by 2030. Now this is a pretty modest recommendation, but as we're going to see from some of the figures that follow, it's also an ambitious recommendation. There is also work to suggest that increasing that surgical workforce to 40 will also result in very significant gains in patient safety. We think it's very important that we collect specific anaesthesia workforce data, and there's 2 main reasons for this. One is the particularly low profile of our specialty, especially amongst public health people. And it's also, we have a quite a complicated workforce with different provider types. Specialist physicians, non-specialist physicians, also a range of non-physician providers. The WFSA has 135 member societies representing anaesthesiologists in 150 countries worldwide. And we think it's very important that these anaesthesiologist societies play an essential role in both the collection and monitoring of this data. So today is a very exciting day for us at the WFSA because we're launching the WFSA Workforce Survey online, and the survey will also be published within the next few weeks online as well. So the plan with our survey was to collect detailed information about the global anaesthesia workforce, physician anaesthesia providers, non-physicians, and as you see, their numbers, distribution and training. And a second very important part of our survey is to establish an online interactive map that can be updated continuously. So here are some of the survey results, and some of them won't be of much surprise to you, but some of them are also quite shocking. Firstly, we collected information from 153 countries. The people in those countries represent 97.5% of the world's population. The survey has revealed massive workforce disparities between WHO regions and between World Bank income groups. Now firstly, here's a picture of the survey, and Julian is going to go over this with you interactively online in just a few minutes. But as you can see, there are lots of different colours on this map. On the top line here, we've got the workforce density of physician anaesthesia providers per 100,000 population. So the red one is less than 1, orange is 1 to 3, so on up to the dark green, which is greater than 20. And you can see some patterns there that are not surprising. So massive disparities between sub-Saharan Africa, Southeast and South Asia, and parts of Europe, North America. And this is not surprising, is it? But what I think is surprising and really worse than we'd expected was the degree of disparity between these regions. So we've got Europe, the European region, with a workforce density of almost 20 per 100,000 population, going right down to the African region and the Southeast Asian region with 1.36 and 1.2 per 100,000 population, respectively. So massive disparities. What this graph doesn't show is that there are also massive disparities within regions. And we have detailed many of these disparities in the article that's being published, and this information will also be available online. If we turn to analysis by World Bank income groups, look at the difference here. We've got almost 20 per 100,000 in the high income group, and the low income group is 0.19 per 100,000. So there is a 90-fold difference in the density of physician anaesthesia providers between high-income countries and low-income countries. And the problem here is that we're not just talking about provision of patient care, but we're also talking about a lack of leaders and also teachers in the poorest countries. So what density should we aim for? What workforce density is required? So you will recall that the Lancet density was 20 specialist physician providers per 100,000, and that is surgeons, anaesthesiologists and obstetricians. We don't know at this stage how many physician anaesthesiologist providers are required and how many non-physician anaesthesiologist providers or anaesthesia providers are required. But we know that we need to increase the numbers to develop anaesthesia services, to provide those leaders and teachers. We also need anaesthesiologists to deliver patient care and to lead and supervise the delivery of care in those places where non-physician providers are used. So we have set an interim target of at least 5 physician anaesthesia providers per 100,000 population. Now there's already been a lot of debate on this target, and we could have set it at 10. But this number gives us something to start with, something to provide some modelling, something to start discussion. And we see this as a first step towards adequate provider numbers. So what does this mean? Currently in 77 countries, the physician anaesthesia provider density is less than 5 per 100,000. So that's 77 out of 153. Even if we add in the non-physicians, the density is less than 5 in 70 countries. If we were just to raise the number of providers to that very modest total of 5 per 100,000, we're looking at 136,000 providers, physician anaesthesia providers now, today, to increase that overall number to 5 per 100,000. And that doesn't take into account increases in population or increases in surgical requirement. We also need to be collecting more information on physician providers, and this is an ongoing source of work. I just want to finish very quickly by saying that as an organisation, we have recently unanimously passed a position statement on anaesthesiology and universal health coverage. As you will appreciate, we are an organisation with many, many societies worldwide, and there is also great differences in viewpoints about models of care. But there was unanimous support for the concept that both physician anaesthesia providers and non-physician providers will be required to address this massive deficit in workforce. And also that physician anaesthesia provider leadership is essential. Now with that, I'm just going to leave you with the website address for the interactive map. We're going to change over a computer, and Julian is going to go through and demonstrate some features of the map. Thank you, Julian.
Oops. Okay. Okay, good. Okay. I've got about 3 minutes. So the best thing to do is actually, after this, please visit that website and go and have a look at this map and play around with it. I think that if a picture tells 1,000 words, that's a great thing. This map tells 10,000. It's a wonderful tool. It's open source, so it's there for everybody to use. So you can see that we've added a few more countries since we actually wrote the article. So we now have almost complete global coverage. And one of the great things about the map is that first of all, it gives the very strong visual picture of where the gap is and where we need to be focusing our attention. It also allows you to very quickly move over the countries. So I can quickly show you, there in Germany, 30 per 100,000 physician anaesthesia providers. Let's zoom up to Norway, 25.5 physician anaesthesia providers. But look at the nurse anaesthesia providers there in Norway. Okay, it's different in each country, the kind of providers that you will find. But there in Norway, 2,000 nurse anaesthesia providers, so more than 50 trained anaesthesia providers per 100,000 in Norway, with those very, very high numbers. If we look at the situation in Namibia, you'll see 110 physician anaesthesia providers, and that situation, if we then click into the map, which I won't do now, gets explained further on. Of those 110 in Namibia, 95 are in Windhoek. 95 of those are in the capital city. Of those 95, 90 are working in private healthcare, and the 5 that remain only work part-time in public healthcare. So there's a lot of information that you can also put behind the map, which we don't have time to do today. Let's just click finally on Zambia. If I click on the country, the map will allow me to zoom in, and then I can, oh, no I can't. All right, I'll just talk you through it then. If you go past that, after that page, it brings up a second page, which in that case would have shown you more information about Zambia. Yeah. So what I encourage you to do is to please all go and have a look at the map, because it is an absolute mine of information. And what we hope is that it will also be a really, really useful workforce planning tool, both internationally and regionally and nationally. Thank you very much. Oops.
Very exciting, thank you. Where are the students when you need them for tech help, right? But I wanted to, since we're running a little bit behind, and for those of you who are online, we hope you're all in cooler places and enjoying the online, and we're really appreciating that you are joining us. I'm now going to ask my other new colleague, Mr. Brendan Allen, who's the CEO of the G4 Alliance. He's the executive director of what is known as the Global Alliance for Surgery, Obstetrics, Trauma, and Anesthesiology. Brendan is a nurse, and he has over 25 years of experience working in the health sector, and I think we're really happy to have him as part of this movement. And he's going to introduce a few of our additional colleagues who are members of the Alliance and supporters. And then we're also knowing that there are many key members here in the audience, so we're hoping we can have a bit of a discussion as well. And we'll also open to questions about the workforce analysis.
Thank you, Chris. I'm very delighted to be here today representing an organisation with another very long name. So let's call us the G4 Alliance. We represent a network of over 80 global organisations dedicated to advocating for the billions of neglected surgical patients around the world. And I'm really pleased to be able to welcome and acknowledge a large number of our members in the room today. I was delighted when Chris invited me to join this session as a moderator, as civil society partnerships are at the core of our work as a member network. This year's World Health Assembly marks 2 important anniversaries: the unanimous approval of WHA Resolution 68.15, which recognised the importance of strengthening surgical and anaesthesia care as part of universal health coverage, as well as the launch of the G4 Alliance, our network that was mobilised to support civil society engagement and coordination in support of increasing access to surgical and anaesthesia care as part of universal health coverage and health system strengthening. So I'm really pleased to be able to welcome an exceptional panel of speakers today to represent some of the innovative and inspiring initiatives being led by civil society, as we've seen with Julian's map. And so I'd like to welcome back to the floor, if you have time, Dr. Miranda, who I was quite inspired by his speech of his inspiration of walking past the hospital, the operating room window. So I'm pleased to say that you've obviously seen the light and entered into the world of surgery. I'd also like to welcome Chris Torgeson back to the floor, who I don't think has actually been formally welcomed, who's the global CEO of Lifebox. Chris is the first and is the first global CEO of Lifebox. She's a former Secretary General of Médecins Sans Frontières and joined the organisation in February of this year, the next step in a career dedicated to health and humanitarian work worldwide. I'd also like to welcome to the panel Dr. Janneke Mellon-Olsen, the President-elect of the WFSA, as well as a full-time practicing anaesthesiologist in, this is going to cause me trouble, Bærum Hospital. In Norway, Dr. Mellon-Olsen is past president of the European Board of Anaesthesiology, where she led the process of developing the Helsinki Declaration of Patient Safety in Anaesthesiology. And also Dr. Ruben Ayala, the Senior Vice President for Medical Affairs at Operation Smile. Ruben's a good friend and a physician and public health specialist from Panama with 23 years of experience with Op Smile. He's also a board member of the Global Alliance for the G4 Alliance and is a representative of Operation Smile at the WHO's Global Initiative for Emergency and Essential Surgical Care. And finally, a thank you and welcome back to Dominique Verwoerd, the co-chair in International Student Surgical Network. So, thank you everyone for joining, and I'd just like to open up with just a simple question, perhaps starting with Ruben, of what, just very briefly, what your organisation does and how you contribute to global surgery and anaesthesia in the WHO resolution. Or perhaps you might like to show a video.
Actually, the video is a little better. Let's have that. So first of all, I got to say, Julian, that the Minister of Health was in the HVC waiting for the Zambia, so you can't let him leave Geneva without actually showing that. I don't know, Minister, if you look behind you, this is another surgery that is really quite exciting. You know, so, but I suppose that someone else will tell you hand surgery is important. Someone will tell you burn surgery is important. Someone else will tell you neurosurgery is important. But the reason that the organization that I have the pleasure of working for exists is the children who are born with cleft lips and palates. And this is something that can actually be fixed surgically quite, I wouldn't want to minimize it, but actually this is something that can actually be done. So over the last 35 years, our organization has evolved from being an organization that was doing missions to an organization that was creating local foundations, to an organization that was started to do local programs, to an organization that ended up doing comprehensive care in centers around the world. So that whole environment is there for us, and we're really proud of the fact that 75% of the work that we do is done by local providers, by low middle income providers. If you look at that, we can celebrate all we do, but in reality, the reason we're all here is because there are a lot of things we're not getting done. So when you go to any of the countries where we are, we continue to see patients who are coming to us, the lack of ability to provide all the care to all the patients, and patients who should have been taken care of when they're months old, having to live an entire life with something that could have been fixed. And there's a measure of social injustice and a tragedy, sort of as you were expressing before. So the organization at some point said, listen, we've been doing this for a long time. So we'll continue to do the same thing, and we might not ever get to the point where we're taking care of every child. So we have actually said that our strategic sort of focus will be on trying to use our efforts towards eradication of the surgical cleft backlog as a catalyst for us to engage in a much broader field or forum of increasing surgical capacity. And that frees us up to really work together with all the organizations that are here, with all the organizations that are sitting here with us, with civil society members, with academia, with the WHO, with industry, and certainly with the government, and last but not least, with our community. So today, a little bit later, I'll show you something about our community engagement involving students, and I'm very excited to be able to share with you. But certainly to just be here, I'm very humble and honored to share with your experience.
Thank you, Ruben. Really looking forward to seeing that. Dr. Mellon-Olsen, you're president-elect of an extremely large organisation, the WFSA. I'm just wondering what your objectives are for the future for surgery and anaesthesia care.
Well, actually, I think that we have just... is it not on? Okay. I think we just heard some of it, because as Dr. Morris and Mr. Gore Booth demonstrated to us, and that's the huge workforce gap, which we have to address, because if we don't do it, who will take the lead on that? And that's one of the good things about our World Federation, is that it's all countries working together towards the same goal. We all want to give the patients the best care and to have resources to do that. In addition, what we are doing, we are doing the workforce, but also the statement that anesthesiology should be physician-led, but as the situation is as it is now, we have to lead by helping others to provide services, so that we have to take the lead for that. And then also not at any standard. So we are doing the safe standards, you know, the SAFE's international safety standards for anesthesia. So these are three very important parts that we have to do and work on together with our partners. Other than that, you can see here what we are doing, what means we use to do that. It's through education and training, which is very important for us. Advocacy we are talking about, but we have to think new ways. We have to lead innovation and research together with, you know, we can come with scientific input and so on, but we cannot get anywhere without partners. We need to work with partners in the clinical side, politicians and everybody to get things done. And then finally, as I have touched upon, safety and quality. You know, we need to make sure that the patients, every patient has the same value and should be treated safely. And we see that there are some initiatives trying to close the gap, but doing it in an unsafe way. So that's one of the other things. I could have continued for a long time, as you can hear, but...
Thank you. That's the role of the role of WFSA in patient safety, clinical training is just fantastic, and to be able to hear, understanding the extreme needs that are still around and needing to address those. That work and the work of many other members of the G4 Alliance addressing those issues is really inspiring. I'd like to ask you, Chris, what Lifebox,
Thanks.
Where Lifebox may be heading.
So thank you so much, and I'll be quick because I think we want to open it up. But so Lifebox started is a global charity, started about 6 years ago by a group of anesthesiologists and surgeons, some of who worked with our colleagues in Zambia, in fact, who helped to develop the surgical safety checklist, which has been adopted by WHO as a simple tool to help reduce mortality and morbidity, and shown to be very effective in promoting safe surgery. When they looked at the surgical safety checklist, they recognized that there was a piece of equipment that they felt was really essential to ensure that was in place for surgeries, and that's the pulse oximeter, which is used to monitor blood oxygen levels during anesthesia. And so this group, and I coming new to this organization, I was amazed. So what did they decide to do? They said, well, they're too high priced, and they're not really, the ones that are on the market are not really developed for low income settings. So why don't we figure out how to procure one ourselves that we can get for low cost and that's adapted for low resource settings? So they set about forming a group called Lifebox, and to actually put out specifications with the help of WHO and to procure pulse oximeters, and you saw them in some of the pictures. We have one out front. They look like a little iPod, and they are really resilient, and I've seen them in action, and then help to work in what I call really a colleague-to-colleague approach. So the whole idea is really what can we do to help our colleagues, the surgical colleagues, our OR nursing colleagues, our anesthesiology colleagues, to have the tools and the training and the know-how to be able to provide safe surgery. And so the pulse oximeter was the first program that was developed by Lifebox, working together very closely and founded with the WFSA and all really dozens of national anesthesiology societies who helped to identify where the needs were, organize trainings, and now has distributed about 13,000 pulse oximeters in over 100 countries. Now we are, with the support of the GE Foundation and colleagues in Ethiopia, we're just showing the first really very promising results on a program, also checklist-based, to reduce surgical site infections, which is a critical component and a very high cause of mortality and morbidity related to surgery in low and middle income countries, but as we know, in a need in elsewhere. So we're hoping to expand that in Ethiopia and then elsewhere as well. So that's where we are now, and we look forward to really working together with so many partners to build this movement.
Thanks very much, Chris. It's been incredible to see the growth of Lifebox over the last few years and the impact that the program has had in the countries you're working in. I'd like to now ask Dominique, who I'm very inspired by the video and the importance of translation and language in being able to pass to communicate our message on. I'm wondering, Dominique, I'm going to flip the question and asking you what you might need from partners in this room and beyond to continue your work.
Thank you, and it's a pleasure to be here on behalf of the future of the OR and the future of global surgery. So InciSioN is the International Student Surgical Network, and we're the largest student-run global surgery network of over 2,200 members in over 17 countries. As you can see behind our, besides our general network, we have over 14 established national working groups all over the world. Now, being just students, it's hard for us and sometimes also daunting to take up larger projects. And we have students and student networks for us to guide and to transition into our studies. But what we would like to ask to our partners and everybody here in the room is to have support in guiding us through our studies and to transition into our professional careers, and to have a mentor or a mentor organization to be able to perform research in global surgery to transition into our professional careers, etc. Thank you.
Thank you very much, Dominique. I'd like to ask Dr. Miranda a question, and thank you very much for your earlier presentation. And you described really clearly the role of civil society, or your vision of the role of civil society. And that was essentially advocating for surgery, particularly the allocation of resources, implementing and providing services and training. I'm wondering now, with you have your vision of the role of civil society, and Zambia now has the National Surgical Obstetric Anesthesia Plan. What do you need from the members in this room to support the actual implementation of that plan?
Thank you very much. The members in this room can do quite a bit. Just to go back to my earlier comments, let me also add to the list research. Now, I tell you a story about some of the successes we are recording in Lusaka with the rearrangement of surgical services within the city. One of the problems we have been confronted with is one national hospital that is congested. and doing surgeries from the most minor to major surgeries, but the bulk of the surgery is actually minor surgery, and that clogs the surgical space. So we looked at how many people were working in the facility and realized that we could use what we had better. So we redistributed the human resource we had in the peripheral clinics that had capacity to do some level of surgery, but did not have a person to do the surgery. So we sent an anesthetist, a surgeon, and what we have seen is a 30% reduction in referrals to the main hospital. Whereas a bed on the floor was commonplace. If you find one now, take a picture and I'll pay $100 for it because there are none. So what I'm saying is that I think that we need to look at what we have and see how best we can use. We have to be innovative in how we deliver services and how we can use what we have. So now, if I'm going to convince the Minister of Finance to put more money in the efforts that we are making, it would be interesting if I can convert what I've just talked about into value terms, into money terms. If I can put dollars to this, just how much have I been able to save by taking surgery to where the patients are coming from, as opposed to treating them in one centralized place. Remember, if we're going to achieve universal health coverage, there should be no catastrophic costs that the patient must incur. So again, doing surgery close to where they are found is cost effective. But I need to put this into some sort of evidence, package it in a policy brief that is easy for decision makers to make decisions. I also know that a lot of you are doing many things, and I think what you should be looking at, the question should be, can you do more to ensure increased access to surgery with whatever efforts you're making? So if you're targeting districts, can you go lower, for instance? If you are trying to train anesthetists, can you find a way to train anesthetists that allows you to train more within a shorter period of time? There are better ways to impart skills. So I'm expecting a lot of things from this group to help implementation of the plan. In Zambia, we have an interesting opportunity that the person here has to make some of the major decisions about surgery in the country. So the action plan has a good future.
Yeah.
That's wonderful and very exciting, Dr. Mwanda. Thank you. I have one more question for Dominique before I pass back over to Julian for questions from the floor. We will have time for a few questions. But Julian, I'm really interested in the student engagement really interested in student engagement and civil society, and I'm fascinated that I'm interested that you describe yourself as the future of global surgery. I think you are a part of global surgery now, so I think that your role is wonderful. But I'm wondering if you can just give us brief. I'm wondering if you can just tell us briefly your thoughts around student and civil society engagement.
Thank you very much for your kind words. 2 years ago, shortly after the passing of the resolution, we as InciSioN, we started Global Surgery Day on May 25th. The past 2 years have been very large and successful social media campaigns, but this year we're trying to take it a step further with, for example, screenings of the checklist effect and the translations thereof. And as you have seen in the trailer earlier today, the checklist effect is now available not just in English, but also with Dutch, French, Spanish, Portuguese, Arabic, and Hindi subtitles. To celebrate this, but also to spread awareness about Global Surgery Day, tomorrow on Global Surgery Day itself, we are having screenings in countries as diverse as Brazil, Pakistan, Rwanda, India, Australia, and so much more. Besides these in-person events, we are having yet another social media campaign, which is mainly focused around the hashtag Global Surgery Day, but also around the hashtag the checklist effect, to not just highlight our collaboration with Lifebox, but also to stress the importance of the surgical safety checklist. So, of course, we would very much appreciate it if you all here and back home could support us tomorrow in spreading the word about global surgery, but also Global Surgery Day itself. Thank you.
Hashtag Global Surgery Day.
Well, thank you everyone. I'd just like to invite Julian back up to the floor. Yes, my notes tell me that I'm allowed to escape from the moderator's role. And
he's gonna let me do it, yeah.
Perfect. Thank you, Chris.
Actually, I thought it would be, since we are a little bit over time, and I thought it would be really great if maybe we took a couple of questions from the audience, also for the for Wayne and for Julian about the workforce analysis, since they had to go through that quickly, and Yannick was here, and then I think maybe we'll just do a rapid fire. What do you hope happens by next year's WHA? But questions? Andrew.
Thank you. Andrew Jones from THET in the UK, an organisation committed to workforce development. I just wanted to pick on something. I think this is directed at you, Ruben, more than anybody else, but others may have a view. How can we adjust the situation where very often surgical missions undermine the skills development of or even the employability of the locally qualified health workforce, particularly in surgery and anaesthesia? And I was pleased to hear your references to strengthening the local workforce, but a recent conversation I had with the previous Minister of Health in Haiti indicated that because of the number of people coming in and just getting on doing the work and then leaving, there were qualified surgeons in Haiti who are unemployed. And this can't be right. And how do we begin to correct a situation like that? I'm also just interested to know whether that's an issue in Zambia too.
Thanks, Sandra. We'll take two other questions, please.
About 6 or 7 years ago, can't remember exactly, Lord Nigel Christ in the UK set up the Zambia UK Health Workforce Alliance. And that introduced 4 degree courses, one of which was anaesthesia. And I think the first guys came off the top about 2 or 3 years ago. Could you tell us a little bit about how many qualified, now these are physicians, are actually coming on stream each year?
Great. I'm going to take your question.
I think you all can hear me.
Yes, please go ahead.
I'm from Nepal, and I'm an orthopedic surgeon, now working for an NGO trying to help the global surgery in Nepal. Question to WFSA. In Nepal, let's say, I think the anesthetist population is less than 1 per 100,000. And we have also anesthetic assistants. We call them anesthetic assistant at the NPAP, and that's about less than 0.3. I mean, in Nepal, the biggest resistance to start this course, we started that course. It's a 1-year academic course. for physicians, for nurses and health assistants. But the biggest resistance we got was from the anesthetists themselves. Now, does WFSA have a sort of a guideline or some sort of pressure to the anesthetists in LMIC countries where you tell them, okay, it's good enough to have these anesthetic assistants and
Great. Maybe before we forget all of those, I'll ask Dr. Mellon Olson to reply to that one, and then Dr. Mwanda, and then Ruben for the first one.
Thank you very much for your question regarding Nepal, because I've been there several times and I have discussed exactly these issues with Nepalese colleagues and other colleagues in low and middle income countries, but also in high income countries. And it's understandable that some of those physicians are resistant because it's their bread and butter, and you know, it's culture and history and so on. But what we are saying, if you look at those figures, which we said, if we are just looking at the bare minimum of physician providers, 5 per 100,000, tomorrow or today we will need 136,000. You know, the numbers just do not match. But what we think is that if we need to take the lead as physicians, and that's what we had to work with our members, and many of them agree also that we need to take the lead to educate, to oversee, to try to support those who are not physicians. And also we can mentor people, you know, so that we should not make we are in this together. But I'm not saying it's easy, but if we do not work together, we just will never succeed. So thank you.
Dr. Mwanda, do you want to take
Thank you very much. The question on medical missions and how they influence systems strengthening. I must say we're seeing a little bit of this in Zambia, but in fact, let me give a specific example. We have trained a lot of ophthalmologists, and so most of this ophthalmic surgery we are able to do except retinal surgery. So from time to time we get missions to come and do, say, cataract extractions. And we have said the way to do this, and incidentally we're getting some doctors come out of the UK to come and do this. We're looking at what our gaps are in terms of where services are available and where services are not. We're also looking at the availability of consumables, because sometimes the reason surgery is not done is because you don't have the materials. So if a mission can provide the materials, surgeries will be done. If we have everything we need, we look at where is the surgery not available. So you'll not come to Lusaka and do cataract extraction. You are going to go to some place in the north on the border with Tanzania, because that's where people need it and they cannot get it. If they do, they'll have to spend a lot to come to the nearest facility. So I think it speaks to the planning of the mission and making sure that you accept help because it is going to be useful, and not accept help when it is going to be counterproductive. Yeah, but how does this then speak to training of the locals? In fact, one of the things we are doing around ophthalmology is that you bring the resources, because my problem right now is where do I find the resources to deploy my ophthalmologists to the remote places? So if the mission is about providing the resources, I have the people to take to a particular place. So the planning of it is very important. However, we are seeing some problems with complex surgery, like open heart surgery, for instance, that you have a team come out of Italy or the UK, they do 10 open hearts in 10 children, and they brought all the equipment and they take off with it. And that is not the right way to go. And we are insisting that there must be a plan to capacitate the local people and also help set up the service within the local hospitals. So I guess how you plan it is very important. What we've done with some of our missions is that prior to the mission, our people have visited, say, a UK hospital for argument's sake, and they've spent an attachment period of a few months. And then the mission follows, and that works as practice, hands-on practice for those staff. And, eventually we can see some capacity building. The physician anesthetic training in Lusaka is going on, I must say, but far below our expectations. We're putting out something like 6 every year, and that is a drop in the ocean. So we hope that this can grow. We have had a lot of challenges around anesthetic training. We used to have a cadre of staff called clinical officers, who were the main providers. However, some mistake happened within the way we manage human resource, that clinical officer anesthetists could not progress to senior chief and so on. And so when they trained to be anesthetists, they remained at the same level, whereas ENT clinical officers would progress, for instance, orthopedic clinical officers would progress. I don't know how that came about, but of course we are addressing that. But the result was that we could not get them into training because it was not attractive to be clinical officer anesthetist. Yes. But we've gone further to begin to train nurse anesthetists. We are going to put out the first 10 before the end of the year, and hopefully this will also help provide the gap. So yes, it's going on, but it should grow.
It's a great question. I would say, because of the mistakes of the past, the mission model has sort of been targeted, but I still believe, and even though my organizations do many other things than just missions, I still believe it has a role to play in reaching the farthest and to reach and the poorest. A couple of years ago, we actually published something we felt was important, and we call it the responsible mission model. And that included things such as making sure that you were integrated into the Ministry of Health efforts, that you were inclusive of the local healthcare workers, that you trained together with local health workers, that you offer a sustained commitment. It wasn't just sustainability. Some countries might not have economics, but you have to have a sustained commitment to not letting things just drop. You have to have empowerment of the local providers and the local leaderships. They really ought to be the heroes of any effort that is undertaken because they have that responsibility. And in my personal experience, I saw that happen where I was born in Panama in 1992. Saw hundreds of kids. By 1997, the Panamanians were doing it by themselves. So that was success and sustainability. That's why I believe in it. But the economics also allowed for that to happen that quickly. In some other countries, you need a sustained commitment. But there is a responsible mission model that can play a role.
Thanks. I will take 2 quick questions, I think, and also interventions from anyone who wanted to say what they're doing also as civil society. I'll take T back here, and I see one more in the back. Oh, I'm so sorry. You actually had your hand up before, so please go ahead. You start.
I represent the World Federation of Neurosurgical Societies, and our model for trying to be sustainable in training, because workforce is such a huge issue in neurosurgery around the world, has been to have twinning between developed nation residency programs and developing nation residency programs, and it works very well. But the question I have is this. We have found that it is very hard to scale up and to speed up because of legal and insurance restrictions. We are attempting a bi-directional model of training of residents where, for instance, North American residents go from Duke University to Uganda to a specific site and vice versa. But it's all done at the resident and faculty vacation time because the licensing bodies, both within the organized profession as well as the insurance carriers of the various hospitals, don't permit hands-on approaches that are within the spectrum of insurance. Has anyone solved that legal administrative problem that's really slowing us down?
Take your point, and then we're going to close.
Thank you very much.
Please.
That's an excellent question. The plan has been costed, and I'll ask Dr. Ntele to give you the exact figures, but let me say about these figures that they are nothing out of this world, because there is some basic something already, and we are merely building on what is already existing. So you will get the figures, but the figures are not that out of this world. Actually, if you hear the figure, you'll be surprised that it is the kind of figure. So, Dr. Ntele, did you want to say what the total cost is?
Yes, it's $314 million.
Okay, that's over what period?
Over a period of 4 years, up to 2021.
You can see they've got a plan and they've got the price tag.
So, can I just add that obviously financing will be important, and the financing needs to be sustainable. Of course, in the initial period, we will require a lot of support from partners, but even as a country, we're making efforts to increase domestic financing. So we're putting in mechanism to increase domestic financing for healthcare in general. And just for your information, Cabinet has allowed us to take to Parliament this sitting the social health insurance bill, which will provide some more resources that can be deployed for this. So that's just one of those. But I think that we are set to make sure that we find sustainable domestic financing mechanisms to continue to finance the health services. But of course, in the beginning, we'll require a lot of support from elsewhere.
Thanks. And I think we don't have the answer to your question on the legal, and it's really important to highlight that here in front of so many colleagues who I think also have that issue. And this is why working together is the only way that we're going to change some of those barriers, identifying them and then finding ways to overcome them. Because of time, and I want to just ask very quickly from each of the panelists, when we come back next year to the World Health Assembly with a new Director General in place, and what do you hope to see in 2 sentences, please? Dominique, should we start with you? And what, from a student perspective?
In terms of student perspective and in terms of global surgery itself, then is that I hope that next year and in the year that comes, that more and more students will be involved in global surgery, whether it's through networks like InciSioN or in their local levels.
Next assembly, I would like to be standing before you to present to you evidence that it can be done.
And that links to me, because I think what you said about the price or how much it costs, as a Lancet Commission showed, it costs much more not to do anything. So that's something for the countries. So I hope that your model has spread all over, so all the other ministers in the world have listened to you, and Even though the older I get, I think experience is very important and getting wrinkles and so on. But I hope that the students have taught all of us and all the others to use social media to work on this, because that's a way we can really change things.
I would love to see greater collaboration between organizations such as the ones that we have here, more public-private partnerships, actually allowing us to succeed in the goals that we have. We've been very personally invested with Vietnam and Nicaragua in looking at processes that will lead to a surgical plan. So I would love to have more countries following the example of Zambia on a national surgical plan.
I'm going to say ditto, 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 ditto. And then also that next year, I hope we'll see Dr. Tedros chairing a high-level panel on safe surgery and anesthesia and taking up many of these points. And I hope we'll be moving toward that in the next months. So with that, I'm going to let my colleague Julian close out this afternoon, and thank you all for coming.
So just a few words to close, and then please join us for a coffee. I think, what are we looking for when we come back? I would like, I think, to put out a personal and an organisational and a collective request from this room to Minister Tedros to say, can we have a formal reporting mechanism against WHA Resolution 68.15. We need a global reporting mechanism for surgical, obstetric, trauma and anaesthesia care and indicators, metrics and targets. We know that if we can get that in place, there is really genuinely more of a chance that we will make progress in this area. I am honoured to be in the room with the Zambian delegation, and we call upon those that are engaged, particularly those from low and middle income countries who are engaged in the national surgical planning process, to be the example for others and to help us to make those plans a reality. Together, we are all involved in making those plans a reality. And I hope that we will have a huge amount to celebrate together in the years to come. I'd like to thank Lifebox, our friends and partners, for co-hosting this event with us. I'd like to thank the G4 Alliance, InciSioN and Operation Smile for joining us, as always, together in our shared mission for the 5 billion people who do not have access to safe, affordable surgical, obstetric, trauma and anaesthesia care. Thank you very much.